Preview.
Delay to Recompression by Petar de Noble. The most effective treatment for decompression sickness and arterial gas embolism caused by gas bubbles that occur after decompression is the return of a patient to an environment of increased pressure. This is called recompression. Ideally, a patient can be recompressed within minutes of symptom onset. Bubbles would be quickly eliminated and symptoms would resolve. This occurs sometimes in commercial and military diving. However, in recreational diving, even when a chamber is available locally, it generally takes hours rather than minutes to begin recompression treatment. If a hyperbaric chamber is not available locally, which is often the case, recompression may be delayed for days. For divers in remote locations, the question of the impact of the length of delay to recompression on their chances of complete recovery is an important one. In asking this question, it is also important to explore steps that might be taken to mitigate risks. The available data do not provide straightforward answers, so we turned to experts for advice. What determines the degree of emergency in decompression sickness? According to Dr. Jordi de Sola, the degree of emergency in cases of decompression sickness is determined by the severity of its presentation. Severe cases can involve several organ systems and may involve impaired circulation, breathing, and consciousness. Such cases can result in permanent disability or death. Dr. Karen van Housen adds, the following responses represent the collective opinions of the University of California, San Diego Hyperbaric Medical Center physicians. These opinions are based on review of the literature and their collective experience of treating divers with decompression sickness for more than 30 years. In general, the degree of emergency in decompression sickness is determined by, firstly, the time of onset of symptoms following the dive, then cardiopulmonary instability, and lastly, rapidly progressing neurological symptoms. The quicker the onset of neurological symptoms after diving, including motor and cerebellar symptoms and mental status changes, but not sensory changes alone, the more serious the decompression sickness insult is. Any evidence of cardiopulmonary instability is a true emergency. Neurological symptoms that present quickly and rapidly progress are also an indication of serious decompression sickness and should be considered an emergency. Arterial gas embolism with neurological symptoms is a true emergency, and this is excluded from the responses that follow. The experts were asked, starting at 6 hours after symptom onset, how much additional delay to recompression may affect the outcome of decompression sickness. According to Dr. Van Housen, based on very limited case reports and data, it appears that there is a subset of moderate to severe decompression sickness cases where early treatment within 6 to 12 hours may improve the outcome. However, this subset of individuals with decompression sickness has not been clearly defined. The severe cases described previously may make up part of this subset. Regardless, there are numerous cases of decompression sickness that show improvement even with significant delays beyond 24 hours. Dr. de Sola has a different perspective. He says, I've worked in Barcelona's hyperbaric unit for more than 30 years and treated several hundred DCS cases with various severities and delays to treatment. In 1977, we started a prospective study to explore what affects the outcome of treated decompression sickness. The first analysis of 466 cases was presented in 1997 and showed that the delay to recompression was not the significant factor. 3 years later, with more cases, now 554, a comprehensive statistical analysis revealed that clinical findings are the most important prognostic factor for decompression sickness outcome. Our findings were not very popular because they went against the current beliefs at the time. Since then, several reports from reputable hyperbaric centers have confirmed them. A recent retrospective study in the French Navy found that 25% of divers with DCS had incomplete resolution after 1 month, despite a short delay to recompression, with a median of 35 minutes. Longer delays apparently did not significantly increase the risk of incomplete resolution. A critical factor in good outcomes in severe decompression sickness is the quality of combined treatment: drug therapy, aggressive rehydration, hyperbaric oxygen therapy, and critical care assistance inside the chamber when necessary. Might the effects of a delay to recompression affect severe and mild decompression sickness differently? According to Dr. De Sola, experience suggests that the more serious the signs or symptoms, the worse the prognosis, regardless of the delay to recompression. It was believed more severe cases could be completely resolved if recompressed within the first few minutes. But this is rarely possible, even in military or professional diving, and never in recreational diving. On the other hand, mostly mild cases resolve completely, regardless of treatment delay. Intuitively, recompression must be applied as soon as possible, within the rational local limitations. This is the message that must be given to divers at all times. However, today we know of many divers recovering satisfactorily despite having received hyperbaric oxygen therapy hours or even days after onset of symptoms. In contrast, there are also cases of DCS with poor outcomes despite being treated within a few hours after symptom onset. Dr. Van Housen agrees that there may be a difference between severe and mild symptoms. As described previously, the subset of more severe DCS may do better with early treatment. The natural history of mild decompression sickness is that it tends to improve with time, irrespective of the time to treatment. Nevertheless, HBO should still be considered the standard of care for all cases of decompression sickness. Considering the increased risk of accidents with unscheduled flights, what conditions must a patient meet for you to decide to use an emergency air evacuation versus a scheduled flight on a commercial aircraft or ground transportation? According to Dr. Van Housen, each case of decompression sickness needs to be considered individually and should be discussed with a DAN doctor. Anyone meeting the criteria for severe decompression sickness described previously should be considered a candidate for emergency air evacuation. Ground transportation is for individuals with mild, pain-only decompression sickness. Flying on a commercial airliner with mild, pain-only decompression sickness might also be a most appropriate approach, depending on the situation. To this, Dr. De Sola adds, if divers' vital functions are stable and no life-threatening complications are expected, they may be transported with a scheduled flight on a regular airliner. This includes cases of skin or muscular decompression sickness, mild neurological decompression sickness, and even spinal cord decompression sickness in which the lesion is likely incomplete or affects mobility only and or sensitivity to the limbs without causing bladder or bowel paralysis. The patient must be in a stable condition. Also, the patient must be hydrated before transportation and should breathe oxygen during transportation. In cases of pulmonary barotrauma with pneumomediastinum or pneumothorax, divers should not travel aboard a regular airliner due to the risk of life-threatening conditions from further expansion of gas trapped within the chest. If divers with decompression sickness symptoms have no chance of reaching a hyperbaric chamber without delay, what should they do in the meantime? According to Dr. De Sola, this is a difficult question. A very detailed and complete evaluation over the phone or via video conference is essential. The procedure will be different depending on the assessed seriousness of the diver's injury. The procedure will be different depending on the assessed seriousness of the diver's injury. In the case of non-critically injured divers, the following applies. If the injured diver is stable and their symptoms are no more severe than muscle pain, fatigue, mottled skin, or impaired sensation to an extremity, this may be considered as non-critical. These patients must not have any serious symptoms such as bowel or bladder paralysis. In that case, a local physician or medical facility, if available, should be contacted to examine and evaluate the diver. If no medical help is available locally, a detailed phone evaluation should be conducted. Provided the injured diver is conscious, oxygen and oral rehydration should be administered, and a low dose of anti-anxiolytic or analgesics should be considered if necessary. An air evacuation should be organized using the first available commercial or private aircraft. The patient should be transported to a hyperbaric facility that can provide adequate medical care. The hyperbaric facility should be inside a hospital, and so it may therefore not be the nearest hyperbaric facility that is chosen. Telephone contact with the target hospital-based hyperbaric facility must be initiated. In the case of critically ill or injured divers, this applies to cases where there are bladder problems, shock, that is low blood pressure, hemoconcentration or hypovolemia, and possible changes in consciousness or respiratory failure. This includes severe cases of decompression sickness as well as arterial gas embolism caused by pulmonary barotrauma and non-fatal drowning. In these cases, confirm the diagnosis and re-evaluate the severity of the injured diver's clinical condition. Transfer the seriously injured diver to the nearest available hospital that can provide qualified evaluation and proper emergency care, despite the fact that a hyperbaric chamber with an experienced hyperbaric physician may be closer. In the hospital, a physician will apply necessary emergency procedures to ensure the patient's survival. The DAN hotline should be contacted, which is 0800 020 111 from within South Africa, or +27 828 10 60 10 when phoning from abroad. I'll repeat that last number again, +27 828 10 60 10 when phoning from outside South Africa. The best procedure regarding hyperbaric treatment should be decided. In some cases, it may include medical air evacuation to the most appropriate hospital when the patient's status permits it. According to Dr. Van Housen, divers with decompression sickness symptoms should breathe surface oxygen if available. If the diver is conscious, awake, and alert, they should drink fluids and stay well hydrated. If pain is the only symptom, taking a non-steroid anti-inflammatory medication such as ibuprofen or diclofenac could be considered. The diver should avoid alcohol intake. Do not initiate in-water recompression. An additional note to consider: regardless of the opinions expressed in this podcast, each case of decompression sickness should be discussed on an individual basis with a DAN hotline staff. This is in order to ensure proper diagnosis, treatment, and evacuation if indicated. Additionally, these opinions are for recreational divers and do not necessarily apply to technical, mixed gas, commercial, or saturation divers.